Okay, let's dive right into this. Welcome back to The Explainer. Today, we are tackling a massive, absolutely critical area of medical coding and clinical documentation, and that is Category J96, respiratory failure. Whether you are a medical coder, a CDI specialist, or an inpatient billing auditor, you know that mastering this category is just essential for accurate reporting. We are going to build a really solid clinical foundation for acute respiratory failure, or ARF, and then we'll navigate the specific selection guidelines. Here is our quick roadmap for today. We will start with Category J96 Code Foundations, move into ARF as a principal diagnosis, look at sequencing precedence rules, then ARF as a secondary diagnosis, and finally, we'll put it all together with a clinical case scenario analysis. Let's get to it.
Starting off with Section 1, our Category J96 Code Foundations.
So this represents respiratory failure that isn't classified anywhere else. And honestly, the structure here is brilliantly logical. Think of it like a giant puzzle. The fourth character tells us the acuity. Point 0 is acute, point 1 is chronic, point 2 is acute and chronic, and point 9 is unspecified. But the real magic? That happens right at the fifth character. This final digit dictates the physiological subclassification. If the documentation doesn't specify whether the patient has hypoxia or hypercapnia, your code ends in 0. So acute respiratory failure unspecified is J96.000. If the chart specifically says with hypoxia, the code ends in a 1. That makes it J96.01. And if it's with hypercapnia, you are ending with a 2, making it J96.02. That same exact fifth character logic applies flawlessly down the line to all the other acuity types.
Now, what's really interesting about this next part is how we prioritize it. Section 2, ARF as principal diagnosis.
All right, here is the golden rule for inpatient auditors when it comes to the principal diagnosis. It is defined as the condition established after study to be chiefly responsible for occasioning the admission to the hospital. You really want to lock on to that phrase, occasioning the admission. Basically, what actually brought the patient through the hospital doors? What made them say, we need to admit you right now? If that specific condition is acute respiratory failure, then ARF takes the principal spot. To get a bit more granular with the guidelines, this principal diagnosis rule explicitly applies to codes from subcategory J96.0, which is acute respiratory failure, or subcategory J96.2, acute and chronic. But, and this is a big but, we never just guess. Selecting ARF as the principal diagnosis has to absolutely trace back to the alphabetic index, and then you have to verify it in the tabular list. You know the drill. Always trace your steps back to the source.
Moving right along. Section 3, Sequencing Precedence Rules.
So here is where we hit the classic rule versus exception paradigm. Let's say acute respiratory failure is indeed the main reason your patient was admitted. You might think it's an automatic principal diagnosis, right? Well, not always. Certain chapter-specific coding guidelines basically act as a trump card. They take primary precedence. If your patient is admitted for ARF, but they happen to fall under the strict guidelines for obstetrics, poisoning, HIV, or newborn conditions, those specific chapters totally override Category J96. In those scenarios, ARF cannot be sequenced first. It gets bumped down to a secondary position. You always want to keep this decision tree in the back of your mind when you are reviewing a chart with concurrent conditions.
And that leads us perfectly into Section 4, ARF is a secondary diagnosis. Respiratory failure might be listed as a secondary diagnosis if it occurs after admission, or if it is present on admission but just doesn't meet that golden definition of a principal diagnosis we talked about earlier. I really want to draw your attention to that chronological trigger, right there. Occurs after admission. If a patient comes in, they get admitted, and then their respiratory system fails while they are on the floor, that is a huge red flag for secondary sequencing. You simply cannot make a condition the principal diagnosis if the patient didn't actually have it when they were walking through the doors. Let's elaborate on this a bit, because the actual circumstances of the admission dictate those primary and secondary slots. First, like we just said, if the ARF develops post-admission, like the patient's condition unexpectedly deteriorates, it's secondary. Simple enough. Second, ARF could be present right on admission, but it wasn't the actual reason they were admitted. Another condition caused the admission, so again ARF becomes secondary. But here is the tricky one that requires some sharp clinical judgment. What if a patient is admitted with respiratory failure and another acute condition, like a heart attack or a stroke? Well, if both the ARF and the other acute condition are equally responsible for occasioning the admission, and you don't have any of those chapter-specific trump cards overriding you, then the Section 2 C guideline kicks in.
That means either condition can be sequenced as the principal diagnosis depending on the specifics of the admission.
Okay, let's move to Section 5 and see how this builds together in a clinical case scenario analysis.
Walk through this patient's timeline with me. Picture this. Step 1. We have a 48-year-old female who comes into the ER. She is admitted specifically for chest pain, diagnosed with an acute myocardial infarction, or AMI, and she's started on IV fluids. Okay, Step 2. Later on during her stay, her condition deteriorates. She suddenly can't breathe properly and needs supplemental oxygen. Step 3. The physician's final assessment identifies this brand new breathing issue as acute respiratory failure with hypoxia. So, rhetorical question for you. Based on everything we have talked about today, what does this chronological deterioration mean for our sequencing rules? And here is the big reveal. The principal diagnosis has to be the acute myocardial infarction. Why? Because the AMI was the condition established after study to be chiefly responsible for bringing her into the hospital. That was the occasion for the admission. Consequently, the secondary diagnosis is acute respiratory failure with hypoxia. We are connecting her post-admission deterioration directly back to that secondary diagnosis rule we just established. Because she couldn't breathe properly later during the stay, it has to be secondary. And if we apply our foundation matrix from the very beginning of the explainer, we know we need to code this specifically as J96.01.
So let's wrap this up with a high-yield summary. Mastering acute respiratory failure principal versus secondary selection really just hinges on answering 3 core questions. First, what was the primary reason for admission? Second, what was the exact chronological development of the respiratory failure? And third, are there any overriding chapter-specific precedence rules at play, like poisoning or obstetrics? If you lock down the answers to those 3 questions, your category J96 coding is going to be absolutely flawless. But let's be real for a second. How often does clinical documentation actually paint a picture this clear, right? What happens when the physician's notes are total gray area? Well, we are going to tackle exactly that in Part 8, where we look at advanced ARF sequencing and some incredibly complex critical cases. Until then, stay focused, keep learning, and decode healthcare with Harshal.